everyone. Thank you so much for joining us. Welcome to OsteoBites. Happy to have you with us today. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Bhuvana Setty from Nationwide Children's Hospital, and she will discuss a multi-institution study of TGF-beta imprinted ex vivo expanded universal donor NK cell infusions as adoptive immunotherapy in combination with gemcitabine and docetaxel in patients with relapsed or refractory pediatric bone and soft tissue sarcoma, and more conveniently referred to as the TINKS trial because that's quite a mouthful. So we'll be referring to it as the TINKS trial moving forward. Thanks so much, Dr. Setty, for joining us on OsteoBites today. We are thrilled to have you. And thank you also to our panelists, Sona and Andrew, for joining us today. And everyone, please feel free to submit questions during the presentation. If you have any questions for Dr. Setty, just put them in the Q&A in the Zoom, and we will make sure we share those with Dr. Setty. A little bit more about our guest today. Dr. Bhuvana Setty is a pediatric hematologist oncologist at Nationwide Children's Hospital, and her clinical interests include treating pediatric and young adult patients with bone and soft tissue sarcomas and patients with vascular anomalies. She's the director of the Clinical Sarcoma Team, and she's also the Site Principal Investigator for the Sunshine Project, which is an early phase clinical trial consortium supported by the National Pediatric Cancer Foundation. And she also serves as a lead for the Ewing Sarcoma Task Force at the Sunshine Project. And in addition, she's the Site Principal Investigator for CANVAS, which is a consortium of investigators for vascular anomalies. And her research interests include developing translational and therapeutic clinical trials with novel agents for patients with aggressive bone and soft tissue sarcomas. And she leads as the national PI for the TINKS trial, which is what we'll be talking about today, as well as the upcoming metastatic Ewing sarcoma trial at the Children's Oncology Group. Thank you so much for joining us today, Dr. Setty. We are very excited for your presentation. I just have a couple of quick announcements before we get started. Check out our July episode of Osteo, which is our AYA cancer podcast. It just dropped last week. And in this month's episode, our host Mia is joined by Dr. Christopher Kuo, who's a pediatric oncologist at Children's Hospital Los Angeles, and osteo siblings Matt and Valerie to discuss the often forgotten and overlooked children in an AYA cancer diagnosis, which are the siblings. And the idea for this episode actually came from a paper that Dr. Kuo published recently. He talked about the AYA cancer sibling experience since he lost a brother to osteosarcoma when he was in college. And he does a really amazing job articulating feelings that I think are just really difficult to express and explain. It's definitely worth a read. And I'm going to put a link to the article as well as the podcast in the chat. And we also featured Dr. Kuo in our July blog post, so I'll put a link to that in chat as well. It is also July Sarcoma Awareness Month, and so we are all about the patient experience informing research and clinical best practices, and patients and families can help by participating in a survey that's now available to better understand the global reality of sarcoma patients' diagnostic experience. Delays in diagnosing sarcomas are really common, and existing data and publications on sarcoma diagnosis are limited. The studies we do have tend to focus on specific countries, regions, or sarcoma subtypes, and so there are gaps in our understanding at a global level. And so our advocacy partners at the Sarcoma Patient Advocacy Global Network are spearheading an effort to fill this void. And so by sharing your experiences in a survey they've just launched, you will help us analyze the diagnostic process from initial symptoms to post-diagnosis management on a global scale. So I'll put a link to survey in the chat, and Sona and Andrew, that might be something you guys might be interested in taking a look at. So Andrew, could you please introduce yourself?
Hi, my name is Andrew Basaga. I'm from St. John, Indiana. I was diagnosed with osteosarcoma in 2017, but so far I am 6 years NED, and I am currently a rising sophomore at Creighton University.
And hi, everyone. I'm Sona Koczynski. I'm from Trumbull, Connecticut. I was diagnosed with osteosarcoma in November of 2019, and I am now NED. And I am also a rising senior at Tufts University. And with that, I'd like to pass it on to Dr. Setty.
Thank you, Christina, Sona, and Andrew. Thank you so much for having me today. I'm very excited to talk to you guys about the TINKS trial and let you know how things are going with this clinical trial. So give me a minute as I share my slides here.
Sounds good. And while you're pulling that up, I will actually also put a link to the trial on clinicaltrials.gov in the chat.
Thank you. All right. Can everybody see my slides okay?
Yep.
Okay. All right. So I'm going to start with a disclaimer that I am not a basic scientist. And a lot of the preclinical work that I will describe over here has been done by much smarter people than me in the lab with a lot of detail to attention. And it's been work that has been done over the last couple of decades that has culminated into the development of the clinical trial. So we'll talk a little bit about adaptive immunotherapy and how we are utilizing that for the treatment of sarcoma in the context of this trial. So just a little refresher, as we think about it, when our body is exposed to any sort of pathogens, there are many barriers that come into place to try to prevent that from becoming an issue with the human system. So the first thing that is a barrier is like the physical and the physiological barriers, which can be your skin, your mucous membrane, the body temperature, the pH of your body. And if that fails, then your immunity and your immune system sort of steps into action. And just to remind everyone, what are some of the key players in the innate immunity and adaptive immunity spaces? I just put this nice graphic here. But I want to highlight that we will be talking about this little guy who's down here, the natural killer cell. And so as you can see, the natural killer cells are part of the innate immunity, but are not talked about as much. We know a lot more about the neutrophils, the basophils, eosinophils, macrophages, even mast cells with allergies and anaphylaxis. But the natural killer cells, they're sort of the silent players in this role. So when we look at NK cells, or these natural killer cells, as I refer to them during the course of our presentation, what do they do? So these are basically regulatory cells that engage with the dendritic cells, macrophages, some of the T cells, as well as the endothelial cells. And their job is to act as effector lymphocytes of the immune system to control any sort of pathogen. Now, this can be a tumor cell, it can be a microbial infection, and its job is to limit the spread and cause subsequent cytotoxicity to these foreign cells. However, as we know, a lot of these foreign cells, especially tumors, tend to evade the immune system and become cancerous in the human body. So going back to the bench here and seeing what our colleagues have done over the last couple of decades, I'm going to highlight a few things over the next 10 or so slides. So it started very early in the 2000s where this work was being done with NK cells, trying to look to see whether there is any anti-tumor activity that could be harnessed from NK cells alone. And so this graphic shows you some of the in vitro data that is showing cytolytic activity specifically against pediatric sarcoma cell lines, as you can see in the bigger graph down at the bottom. And then the smaller inlet graph on the right, you can see the effect on rhabdo, Ewing, some neuroblastoma, as well as CNS, and some of the other leukemia models that were tested in this study. There was a lot of canine studies that were also done, and this is some data from some canine studies that were done around the same time. As this group is probably well aware, dogs are, one of the mammals that are pretty susceptible to developing sarcomas. And so in lieu of mouse studies, a lot of work has been done in the sarcoma space within the canine population. And when some of these studies were done with the anti-sarcoma NK cell model, what they found was that when you pair palliative radiation with NK cells, there seemed to be a better eradication of metastatic disease in the dog model. And they also noticed that following radiation, there was an enhanced NK trafficking into the tumor microenvironment. And I'll talk about why the tumor microenvironment is important in a few slides down the road here. So the other thing that is important when we look at immunotherapy and trying to utilize this for cancers is that a lot of the immune cells, when they're infused, are destroyed by normal mechanisms that are in the body. And so these studies were done to look at the cytotoxicity of tumor infiltrating NK cells, which were a slightly modified NK cells compared to healthy donor peripheral NK cells that were obtained from just like a bloodstream. What was the important finding here is that when these tumor infiltrating NK cells were expanded in low dose interleukin 2, there was a markedly high suppressive effect with high doses, but the effect was really salvaged in terms of cytolytic activity when they were expanded with the lower doses. And they are at best comparable to healthy donor cells with no mark of enhanced cytolysis when you expand them with the lower dose and IL-2. A lot of these cells were, again, tested in humans in terms of donor NK cells and as well as autologous NK cells that were tried to be infused in various disease types. And this data is from studies that have been done outside the sarcoma population, mostly leukemia and some brain tumors, where they were expanded NK cells were given over about 400 infusions in about 100 patients with many phase 1 and phase 2 trials. There are a couple of NK cell trials in the melanoma and the breast cancer space as well. And the interesting thing is that although they were titrating doses up to as high as 10 to the 8th of the NK cells per kilo body weight, there were minimal infusion effects and no reported dose-limiting toxicities in any of these studies. So getting back to the tumor microenvironment, so if we recall if you think about a tumor mass itself, there usually are many agents that are within the tumor mass and other factors such as the macrophages, the TGF-beta, and many other factors whose job is to destroy predators and destroy anything that are trying to minimize or kill the tumor cell itself. So one of the things that my collaborator, Dr. Lee, noted in his lab was that when tumor cells were exposed to NK cells, they would be destroyed in the tumor microenvironment. And this was thought to be due to the effect of TGF-beta, which is a known factor within the tumor microenvironment. So there was a process that was attempted called TGF-beta imprinting, where during the expansion process, the NK cells were exposed to TGF-beta, and this process seemed to harden these cells, which then, when they were exposed to the TGF-beta within the tumor microenvironment, were not lysed as easily, and they seemed to have a longer lasting effect. So I almost think of it like a shield for the NK cells to be able to have the cytotoxic effect that it needs to within the tumor microenvironment in a patient. So we had to also figure out if these TGF-beta imprinted cells would change the efficacy of what we would expect from the NK cell. So various experiments were done, and what was noted was that there was really no significant effect on the fold expansion of the NK product or the viability of the NK product. So it did not really kill these cells faster, and these products were expanded as easily as a non-TGF-beta imprinted NK cell was. The interesting thing about this was that re-exposure to the TGF-beta within the microenvironment reduces degranulation in typically expanded cells. But this function is preserved in the TGF-beta imprinted cells, as is the cytolytic activity against the sarcoma cell line. And you can see in the bottom figures over here on the right side, where it shows the percent specific lysis and the percentage of the CD107A in the control versus the TGF-beta imprinted cells. One of the problems that was noted with many of the T cell therapies, especially CAR T and other therapies that were coming around at this time during the same decade, was the problem with cytokine release syndrome, and that a lot of patients would have downstream effects of cytokine release, which led to fevers and other devastating side effects sometimes after T cell infusion. So the scientists in the lab looked to see what kind of cytokines were secreted with TGF beta imprinted NK cell. And what they found is that the cytokine secretion is pretty prominent, and it's actually preserved upon re-exposure to the interleukin-2, which is what we want because these also assist with cytolytic effect. However, IL-6 is not a prominent cytokine of any expansion product, both the normal donor TGF, normal donor NK cells, or the TGF beta imprinted NK cells. So it was assumed that cytokine release syndrome should be of a low concern when utilized in the patients. We looked and thought about a lot to determine what would be the best chemo regimen to utilize with these NK cells to allow for a synergistic effect in the body. And what was realized is that the way NK cells really see or activate during in the process of trying to figure out how to attack sarcomas are mainly through the interaction of NKG2D ligand and some of the other subligands, the MICA, MICB, and the ULBP1 and 2. Now, these are all stress ligands, and they're not normally present on healthy cells. Many chemo regimens can actually induce these ligands due to genomic stress on the malignant cells. And we were trying to figure out what chemotherapy regimen would have some efficacy in the sarcoma population, as well as be able to have the synergistic effect with the chemotherapy regimen. And after much thought and discussion, we decided to use gemcitabine and docetaxel, which met the goals of synergistic chemotherapy because the activity synergizes with NK cell lymphodepletion, and it also allows for in vivo expansion of the NK cells, wherein once the chemotherapy is and then you infuse the NK cells, we anticipate that the NK cells will also continue to work actively within the human system.
Dr. Setty, I was just
Nice.
noticing, like in your notes below, it's talking about the evidence for gemcitabine and NK cell synergy. So I'm just curious, like what kind of docetaxel brings to the party?
Yeah, that's a great question. And while most of the studies were done with gemcitabine alone, looking at the NKG2 ligand expression, gemcitabine alone has not shown much benefit in treatment of sarcomas in the past. And the chemo regimens that have been used with gemcitabine have been either docetaxel or nab-paclitaxel. We decided to go with gemcitabine docetaxel in combination because of the most data available with this combination, in addition to prior studies that actually showed retrospective data that showed some responses in osteosarcoma and multiple other histologies of sarcomas with the gemcitabine and docetaxel. And that's why that combination was chosen. For that purpose, and in addition to kind of enhancing the NKG2D ligand in during the therapy.
Got it. Thank you.
Yeah. So while we decided on our treatment regimen, the next thing was to try to determine how to expand enough cells for our patient population. So the way this is done is that these universal donor NK cells are collected basically by a donor blood collection, just like you would donate red blood cells or plasma, and they are then purged to pull out just the NK cells. And there's this whole process, which looks like a simplistic picture on this schema, but it's a very complex process that happens in the GMP facility that we are manufacturing here at Nationwide Children, where there's usually a Buffy coat fraction that's placed on it. The CD3 is then depleted to minimize the effects of any residual T cells that might be might have gotten into that apheresis collection. This undergoes a process of recursive stimulation that enhances these NK cells. And then, it's not shown clearly here, but during the process of recursive stimulation, the TGF-beta is also imprinted at that point. Then these products are then cryopreserved and sent to the bedside or shipped to other institutions where patients are being treated. It is then thawed and infused to the patient at the time points during the trial therapy.
And how long does this whole thing take?
It takes a few days, but the biggest challenge is trying to identify appropriate donors for these collections. So there is also a process of screening for certain HLA markers because we want to make sure that we're collecting the blood from the most common HLA antibodies that would be then compatible with many of our patients. Fortunately, we've had enough donors, and with one blood collection, you can actually expand it to millions and millions of cells, which can be utilized for multiple patients during their treatment.
Wow. And just curious, when you manufacture these, is the goal is that you kind of just have this inventory kind of sitting on a shelf in the freezer, or is it kind of made on demand? Like, do you have
Yeah. So we do have, the goal is to have enough inventory for at least the upcoming, handful of patients that will be enrolling on trial. While we enroll on this study, what we have done is anticipated complete doses of treatment, which is up to 8 cycles, what I'll talk about when we get to the study design, but make sure that we have enough cells to cover that particular patient through the entirety of their treatment.
Makes sense. Thanks.
Yep. Okay. So with all of this data and available information, we were looking to really focus on our sarcoma population. And I don't have to stress too much over here. We know that patients who have metastatic disease at diagnosis and those who have relapse disease really struggle to get to a place where they have no evidence of disease and have had complete remissions for longer periods of time. So with that, the goal was to develop a clinical trial where we would use these TGF-beta imprinted ex vivo expanded universal donor NK cells, which is being used as adoptive immunotherapy in combination with gemcitabine and docetaxel backbone for patients with relapse or refractory pediatric bone and soft tissue sarcomas, also called the TINKS trial. So the primary objectives of our trial are really to determine the safety of the combination of TGF-beta NK cells and gemcitabine and docetaxel, and to determine the 6-month progression-free survival in this patient population. And various secondary objectives, the most important ones were to identify the toxicities, because this is the first time ever that we are using NK cells as immunotherapy in our sarcoma population. And then also utilizing it in combination with the chemotherapy regimen that it has not been used with before. We're looking to evaluate the response rates across various sarcoma histologies and individual histologies, and then to assess the overall survival for this patient population. A few collaborative studies and correlative studies that are being done are to look at the circulating tumor DNA in patients with relapsed and refractory sarcoma receiving treatment under this trial, to evaluate the synergistic effect of chemotherapy regimen on the tumor targets for the NK cell mediated lysis, and then to evaluate the density, phenotype, and actual function of these infused TGF-beta NK cells that have invaded into the tumor microenvironment. In addition, we have one exploratory objective to determine the utility of the iRECIST criteria for the evaluation of response to cellular therapy. So just as a background, for all solid tumors and sarcoma patients, as a standard to evaluate for response, we have been using the RECIST 1.1 criteria, which utilizes a 3-dimensional view of the tumor and determines whether there has been response or not. One of the problems with immunotherapy and also potential issue with NK cells is that there always can be a pseudo progression in the tumor, where the tumor appears to be a little larger before it gets smaller due to the influx of other inflammatory cells and the interaction with the macrophages and the other substances within the tumor microenvironment. So to account for those, the adults use iRECIST as a standard criteria for many of their immunotherapy trials. So we decided that this would be a great study to actually see if any of our patients do develop pseudoprogression, and we could follow the responses with the iRECIST criteria rather than the straightforward RECIST 1.1. So a little bit about the eligibility. We're looking at patients over 12 and under 40. It includes patients with relapse or refractory osteosarcoma, Ewing sarcoma, rhabdomyosarcoma, and some of the non-rhabdo soft tissue tumors. Patients will need to have measurable disease for RECIST 1.1 to be eligible. No more than 4 prior lines of systemic chemotherapy, and no prior cellular therapies or CAR T or other expanded or manufactured cellular products, no CNS metastatic disease, and any tumors that are near critical structures where there could be any transient swelling that could cause substantial symptoms are excluded. And this is in relation to the pseudoprogression that I was describing earlier. We are requesting no systemic corticosteroids other than supportive dexamethasone that is used specifically around chemotherapy to minimize side effects.
Dr. Setty, for the 4 prior lines of systemic treatment, does that include both chemotherapy as well as TKIs?
It does not include TKIs. So this is systemic treatment, mostly referring to cytotoxic type chemotherapy. And the reason for that is mostly that we still want to see our patients having an active immune system and not having received, 6 or 8 multiple IV regimens where their bone marrow is fatigued and will not be able to mount an immune response. Because these infused NK cells, need some lymphodepletion to have an effect, but then they also need the native immune system to be able to act appropriately in the body.
Got it. Okay, so that's more referring to like cytotoxic chemo, not so much TKIs. And then what about prior gemcitabine or docetaxel?
That's a great question. So prior gemcitabine is allowed as long as it has been used at least 6 months prior to enrollment on the study. And if there were no grade 3 or higher toxicities related to gemcitabine or docetaxel that have not resolved by the point of enrollment.
Got it. Thank you.
Yep. Okay, so this is what the study schema looks like. So these are 21-day cycles. Study treatment days are day 1, 8, and 12. On day 1 and 8, patients get gemcitabine at 675 milligrams per meter squared. On day 8, they will receive docetaxel at 75 milligrams per meter squared. And this is surrounded by the dexamethasone, which is usually given as an oral medicine that they take at home starting on day 7 all the way through day 9. And this is to minimize some of the edema and pulmonary toxicities related directly to docetaxel. And then 72 hours later, on day 12, the NK cells are then infused into the system. And I forgot to mention, on day 9, patients will also get pegfilgrastim, Neulasta, or one of those similar products. And on day 12, after they receive their NK cells, they do not have any other planned treatments until day 21, which is the time where we notice that their hematologic function and their counts sort of decline and tend to recover by day 21 when this cycle is repeated all over again. And this is repeated for a total of 8 cycles. We do imaging with scans of the primary site and the metastatic sites that we've been following every other cycle to determine that there is no progressive disease during that time.
And curious, how does this dosing of the gemcitabine docetaxel compare to if a patient was just getting GD just for treatment? Because I know it sounded like you're kind of in that space between you want lymphodepletion, but you don't want to totally destroy the immune system. So just curious how it compares.
Yeah, so these doses were adapted from prior gemcitabine docetaxel studies that were performed. If you look at the dosing, it's kind of all over the place, and depending on the indication, there have been some lower doses that have been used, and a little bit of a higher dose that has also been used. However, considering that the patient population that comes into this trial has already been treated, probably with 2 or 3 lines of therapy, we did not want to use a super high dose. One of the goals of the gemcitabine docetaxel backbone, actually 2 of the goals, one would be to ensure that our patients are getting chemotherapy that has an effect on their particular tumor. So that, because this is the first trial with NK cells, we do not want to treat our patients with purely experimental therapy alone. So in the event that we notice that the NK cells are really not effective, we have still treated our patients with chemotherapy that we know is efficacious for their type of tumor. The second thing, especially with the dosing, is we landed on these particular doses because we really want to get enough of a lymphodepletion by day 12 to allow for the infused NK cells to have room to get into the tumor and expand within the tumor itself to have their cytolytic effect. And from a prior trial that was run through the Sunshine Consortium recently, as well as other studies that did gemcitabine and docetaxel, this seemed to be the dosing that was enough to cause lymphodepletion that we wanted to achieve without causing severe hematologic toxicities. We do allow for dose reduction as well through the course of the study for patients who are not able to recover their counts by the end of day 21, and allow for slightly lower doses of chemo to allow for that continued effective lymphodepletion and continued NK cell treatment.
Great, thank you.
Yeah.
We have one question about whether there is criteria for the NK donors and whether the NK cells are genotyped.
The NK cells are not genotyped. There are in the GMP facility, and this is a standard within our GMP facility, where all the donors would need a baseline HLA testing to be done, so we know what their HLA phenotype is. And the ones for this trial that are being picked are the most common HLA donors that are being used, similar to what would be utilized for, say, bone marrow transplant in that setting. We do not HLA type our patients up front, but during the course of their treatment, we do get panel reactive antibodies, which tell us what HLA types that our patients are maybe developing. And some of these have been contradictory to the donor cells. So there have been a couple of patients on study where we had to switch donors in the middle of their treatment to minimize any potential side effects or interactions with infusion reactions. Okay. All right, so looking at the study design, so basically there's a part 1 and a part 2. And the part 1 enrolls 5 patients per cohort. So the study is divided into 4 cohorts based on the histology. So we've got an osteosarcoma specific cohort, Ewing sarcoma, rhabdomyosarcoma sarcoma, and then the non-rhabdomyosarcoma sarcoma tumor. And in part 1, there will be 5 patients enrolled for each of these cohorts. If you look at the text box at the bottom, those are the criteria that need to be achieved in order to move to part 2. So when one patient in part 1, that is 1 out of 5, achieves a 6-month progression-free survival, then we will proceed to open the part 2 for that particular cohort. And then cohort 1, stage 1, which says an N of 9, includes the 5 patients from part 1. So we'll enroll an additional 4 patients from that diagnosis. At the end of stage 1, we are pausing to do an interim analysis for efficacy. And during that time, we will require that there need to be a minimum of 2 patients out of these 9 who have achieved a 6-month PFS. And then we will proceed to the stage 2 of each cohort for a total of 20 patients. And throughout this process, we will be monitoring for toxicity continuously. And any patient who has received at least 1 dose of NK cell infusion will be eligible for the toxicity monitoring. So this is a two-stage study design with an interim analysis here. And our goal is to improve the survival from 20% to 45% with a power of 85% on this study. Okay. This is just a schema describing some of the correlative studies that I touched upon when we talked about the objectives. So during every cycle of chemo, every cycle of treatment, patients will have peripheral blood drawn as well as any resected tumor for any patients who undergo surgeries to be sent to these three labs. So the Lee lab at Nationwide Children's Hospital will focus on the analysis of the TGF-beta imprinted NK cells in the blood, looking at the phenotype and the effect of these infused NK cells in the bloodstream. If patients undergo any sort of surgeries or tumor biopsies, any extra tissue is then sent to Dr. Mullinax's lab at Moffitt Cancer Center, where he will be looking at the tumor microenvironment and the effect of the NK cells within the tumor microenvironment. And then the blood is also sent to Dr. Mas Hayashi at University of Colorado, who will be studying the circulating tumor DNA cells found in the bloodstream. And there are various time points laid out for these particular blood draws. So right now, our clinical trial is open and enrolling. It has been open since October of 2022. And so far, we have it open at 12 centers. I just put the hospital names over here in case anyone wanted to look through that. We do have a few other sites that are also in the process of opening the trial, so there will be more added to this list in the next few months. And kind of the current status on our patient population. So for the osteosarcoma, our part 1 has completed accrual. Our patients are currently receiving treatment. 4 of the 5 patients are actively receiving treatment at the moment. And we're waiting for their data to mature to determine whether we can expand to part 2. For the Ewing sarcoma cohort, part 1 was completed. We met criteria to open part 2, and now we are currently enrolling in stage 1 of part 2. The rhabdomyosarcoma cohort is also enrolling in part 1 at this time. And then the non-rhabdomyosarcoma cohort enrolled in part 1 met the criteria for expansion and is now enrolling in part 2. So this is where we are with our study enrollments. And because it is sort of a little bit of a rolling study design, I'm hopeful that we will be able to continue to enroll continuously without too many pauses in between. And with that, I just wanted to really thank all the patients and their families who have opted to, get treated on this study and put their faith in the study team with this regimen. I want to thank Dean Lee and his lab for all of his collaboration, Dr. Mullinax and Hayashi for the correlative studies that they're performing, our Sunshine team, who has been tremendous in trying to move the study forward, and their regulatory team who help us on a daily basis with all the clinical trial details, our nationwide cell therapy team, regulatory and radiology team, and so many more people. We have been fortunate to be funded by the National Pediatric Cancer Foundation for the majority of this trial work, including the Moffitt Cancer Center, who serves as our regulatory team. The Isabella Santos Foundation is funding our correlative projects and the correlative studies that are being done. And my own hospital, Nationwide Children's, has been extremely supportive with the trial. So it's been great to continue to offer this treatment to many patients who have come along the way. All right. I will stop sharing, and I am happy to answer any questions.
Thanks so much, Dr. Setty. Great presentation, and everyone, please feel free to just put any questions you have into the Q&A. Andrew, do you want to kick us off with the question that just came in?
Sure. So one person asked, what characterization of lymphocyte infiltration or density and profiles is done on the primary or persistent tumor?
So great question. The goal with the primary, and so we're not looking at archival tumor samples. we are trying to look at tumor tissue post NK cell infusion. So if there have been patients who are on treatment, the trial allows for surgery or any surgical resection after cycle 2. And those are the tissues that we are trying to obtain. So far on study, none of our patients have undergone any surgeries, which is understandably so, because many of them come to us with large tumors or difficult to treat location. But the goal would be to do analysis of those tumor tissues in Dr. Molinax's lab, basically looking at the phenotype of the infused TGF-beta NK cells within the tumor microenvironment. But we're not looking at any archival or primary tumor biopsies at this time.
Dr. Setty, so you mentioned that surgery is allowed after cycle 2. That was something actually that I was just wondering. Also, wondering about radiation and whether or not radiation, where in the timeline is radiation allowed? And especially because in the beginning you had mentioned about there was some synergy as well between radiation and the NK cell efficacy.
Yeah, so radiation is also allowed at after cycle 2. So basically any plans for local control will not take them off of the study as long as we've completed the first 2 cycles, and then we can continue to treat them on trial along with their local control plan. We've had 1 patient so far who is undergoing concurrent radiation therapy along with the IV treatments with the gem docetaxel and NK cells, and thus far has been doing okay. I think it's interesting because we have all the preclinical data to suggest synergy, but it is obviously very hard to know, what that really does within the tumor tissue without being able to biopsy any of these samples. So out of academic curiosity, we'd love to know, but the trial allows for surgery or radiation after cycle 2, depending on the treating physician's preferences.
I think you, well, so one person asked, why not do biopsies after infusion of NK cells? But
I would love to, but as you know, the IRBs do not like biopsies for research only purposes, and it is really hard to kind of build those in. Many early phase clinical trials do not even allow for local control. I was really glad that we were able to include that within this trial. I do think there's a lot of valuable information we learn from post-treatment tumor tissue. And just trying to do biopsies without the goal of a clinical change would be considered a research only biopsy, and I think those have been hard in my experience to get through approval of IRBs and scientific consults.
Another person asked, when you presented your schema, you mentioned you may want to infuse thawed, cryopreserved NK cells or freshly expanded NK cells. Will you have a protocol for which you will choose, or will it be dependent on NK donor availability?
So basically all of the cells that are expanded in the GMP facility are then cryopreserved before sending over to the bedside. These cells are then thawed at the bedside, and they need to be infused within 30 minutes of thawing. So even when these cells are shipped to other institutions, which I think is one of the big advantages of our study, because many immunotherapy studies require patients to travel to one institution to get their treatment. But with the process that has been developed, we are then able to ship frozen cryopreserved product to the treating institution, who will then keep it frozen until they are ready to infuse it to their patient. And the thawing process is, there's usually a standard SOP within most transplant centers, where it is thawed at the bedside and then infused right away by the bedside nurse within 30 minutes.
I was
Um,
wondering how the timing was determined of when to infuse with NK cells after after chemotherapy or gemcitabine.
That's a great question, and we actually had a lot of debate about that timing. So, so the couple of things that we were trying to accomplish with the NK cell infusion is that we have achieved a point of enough lymphodepletion where the blood counts are at their nadir or close to their nadir, as well as being far enough away from the dexamethasone that patients receive on day 7, 8, and 9. With the dexamethasone, there has been some data that has come out from a couple of labs where they noticed that it can be detrimental to the infused NK cells and actually cause them to break down faster. However, there's more recent data coming out that maybe it is not as dangerous. However, we didn't want to take that chance. So we decided 72 hours after the dexamethasone was a good enough time to allow for all of the dexamethasone to be out of the system, and make sure that the NK cells remain intact to have efficacy. And in terms of the lymphodepletion, as you know, usually about 7 to 10 days after your first chemo is when we notice that nadir. So that's really how we decided on day 12. That also gives us about a week post NK cells to allow for patients to recover before we start their next cycle.
Carefully calibrated schedule. Feel free to get up any questions in the Q&A. And one question I was kind of thinking about as you were talking was just about the previous treatment history and knowing that patients coming into this trial may have gone through a couple of chemocycles, and wondering, have you kind of thought about, I'm sure you have thought about this, like how the role of previous treatment history plays into efficacy for, I guess, kind of many reasons. I mean, one is also just the state of kind of the immune cells, but also just things like, resistance and stuff like that.
So let me see if I understand your question correctly. So how does the history of what we know with the chemo regimen play into the efficacy of this treatment?
Depending on the rounds of either chemotherapy or other treatments a patient might have before starting this therapy?
Yeah, so I don't know that any past or prior chemotherapy regimens would really affect anything that would be happening now. One of the hypotheses is that the more chemo that they've gotten can cause, marrow fatigue and immunosuppression that can be sustained to not allow that innate immune response to be effective enough. And that's where infusing the NK cells, where you're doing it from healthy donors, then allows for replenishing some of that innate immune system to have the benefit. We kind of debated whether to allow prior cellular therapy or other immunotherapy to be eligible on this study. But because this is so new and like the first time we're using NK cells in sarcomas, we didn't want to really muddy the waters and not understand the effects of NK cells if they had recently received a CAR T treatment or something of that sort. And so that was one of the reasons for that. I'm not entirely sure how it may or may not change the efficacy of NK cells if they have received a prior immunotherapy. However, we anticipate that there would be some immune remodeling and changes that would have happened from the prior immunotherapy that may affect our trial therapy.
I have kind of some more basic questions about NK cells. So we're talking about universal donor NK cells, which definitely has a lot of advantages in terms of manufacturing and all that stuff. But just, has there been kind of, what is the difference between autologous NK cells, where it's taken from the patient versus these universal donor cells? Is there any difference in things like toxicity or efficacy there, whereas then you just have the advantage of the manufacturing advantages? Any other differences between?
Yeah, so autologous NK cells are basically extracted from the patient's body itself, whereas the universal donor NK cells are just taken from random healthy donors. So, in the relapse population especially, I think our patients are pretty beat down by the time they come to a point where they're trying early phase trial. And the concern with autologous NK cells is first that we may not be able to get enough NK cells from the patient itself because their innate immune system is probably not as active and it's really suppressed. And then secondly, even if we do get them, are they going to be functional enough? Because they have been exposed to chemotherapy and all of the other treatments that have happened already. And so that's where the thought began to try donor cells, which have been used in other solid tumors like melanomas, and some brain tumors have done that as well previously. And so that's where the thought was to try donor cells to see if we could actually give them healthy cells to try to allow for these effects. I think one of the big issues would be, infusion reactions and sort of graft versus host disease that could happen when you infuse foreign cells. Fortunately, because of the process of the recursive simulation and T cell depletion that happens in the lab prior to infusing the NK cell, there's very minimal amount of what would be considered foreign to interact with the human microenvironment and the human body. So that's what we are anticipating, that will prevent a lot of these reactions. I can share that the patients who have been on study so far, we have seen some infusion reactions with, fevers that have lasted for about a day, mild hypotension with drop in their blood pressure, and things like that. And so, we fortunately have not seen any major effects of reactions from the infused donor NK cells so far.
Okay, great. But so it's basically like fresh, re-energized troops as opposed to the tired
Yeah.
army that's already been fighting so hard.
Yeah.
Got it. I think we have another question that came through the Q&A, so if you want to take that one.
How do various naturally occurring substances that inhibit TGF-beta influence the hardening effect of TGF-beta on the NK cells?
Well, that's a little bit of a tough question for me to answer because I'm not the basic scientist and I don't do these in the lab. I could give you an answer, but I don't know the exact response to this, but I can get back to you on that, Dr. Healy.
That's a toughie. That's a, I mean, I guess I kind of think if this is like a correct interpretation, the imprinting is, it's because you're basically exposing the NK cells to TGF beta slowly, that once they actually kind of mate them, they're already kind of like used to it. It's all, I don't know, not to confuse with terminology, but it's almost like giving them like a vaccine, right? A little bit like.
Yeah, I mean, not truly a vaccine because you're not creating a response, but yes, that's why I think of it as a shield. It kind of protects them from any other factors that will attack them later.
Thanks.
I had one more question. I was wondering how the ligands in the beginning, like does the expression of those are those sarcoma specific, like mica sarcoma specific ligands, and does it change in response to, like, has it been shown to change in response to NK cell treatment?
They are somewhat sarcoma specific, but they also are seen on other cancer cells. But then many chemotherapy agents actually enhance the development of those ligands as well. I don't know the answer to the second part of your question, is whether they change with NK cell treatment. And I'm hoping that if we do get a chance to analyze some post-treatment tumor biopsies or samples, then we might know more information about that.
A question about the cytokine release syndrome, and I know you had a slide that kind of talked about this, and I think you said there wasn't as much IL-6, which I guess is responsible for, but just for patients who are thinking about enrolling, I mean, what can they expect? Is there like a little bit of cytokine release syndrome? And if so, is there kind of a protocol in place to treat? Like I think for CAR T cell, there's kind of a pretty like standard protocol now that people have to be able to kind of treat that as soon as they see that happening to minimize any
Yeah,
adverse.
and you're right. I mean, so at all of the institutions that have the study open, one of our criteria for being able to open the trial at a site was that they have an active bone marrow transplant unit and that they are BACT accredited. So that way they are, you know, accustomed to immunotherapy and the side effects that come with immunotherapy treatment. With our NK cell infusions, we request that our pharmacy keep a dose of tocilizumab, which is an anti-IL-6, on hand, just in the event of an acute reaction. If CRS were to develop, we would follow the same protocols that we do for other immunotherapy studies in terms of managing those symptoms. Yeah.
Great. Any other questions? We have a couple minutes left, and it sounded like for osteosarcoma, I think you said that you were already fully enrolled, right, for part 1?
For part 1, yes. I mean, I'm anticipating by the end of the year, we'll have some data maturation and know whether we can expand to part 2.
Got it. Okay. So for people that are interested in the study, kind of stay tuned towards the end of the year.
Yeah.
There's an activity on that. Okay, great. So Andrew, any other questions?
I think so.
All right. Well, thanks so much. That was a really great overview of just kind of understanding kind of how all the things that made up that really long study name. A lot of components to the study. That might be the longest study name I've encountered. But you guys came up with in true scientific fashion, came up with a great acronym. Thank you so much, Dr. Setty, for joining us on OsteoBites today and for making it better for pediatric sarcoma patients. More information on this and all OsteoBites can be found on our website at mibagents.org, on our YouTube channel, and at your favorite podcast place. And we hope you can join us next Thursday on August 1st. We are going to be joined by Dr. Sabina Kazanowska from the NCI, and she's going to be discussing immune determinants of CAR T cell expansion in solid tumor patients receiving GD2 CAR T cell therapy. So a different type of cellular therapy, but a nice kind of follow-on to today's topic. You can find our OsteoBites lineup for the next few months on our website. And if you have any ideas for future topics that you'd like to hear about, please share them with us at events@mibagents.org. And in fact, Dr. Kazanowska was suggested by a listener. So we definitely take those suggestions seriously. Thanks again, Dr. Setty, Andrew, and Sona for spending an hour with us today. And thanks to all of you for taking time out of your day to join us. We hope to see you back here next week on the 1st when we chat with Dr. Kazanowska. Thanks, everybody. Thanks, Dr. Setty. Thanks, Sona. Thanks, Andrew.